Let us first acknowledge and recognize our hardworking team in FIP for another wonderful digital event. For sure, you and I will definitely be learning a lot from the lineup of our powerful speakers. I am Leonila Ocampo of the Philippines, a member of the ExCo of the FIP Community Pharmacy Section and a member of the Data and Intelligence Commission. I'm also part of the Executive Board of the Western Pacific Pharmaceutical Forum. Let us have some announcements. This webinar is being recorded and live streamed via YouTube and the FIP events website. The recording will be available on our website, www.events.fip.org. You may ask questions using the question box provided. You are welcome to provide feedback to webinars at fip.org. And we enjoin you to enlist as members of FIP. Just visit www.fip.org/membership and go to the registration. So I would encourage you to enlist as member and be part of this wonderful family, FIP. Today's event is the second of a series of 2 events called Food for Thought, Pharmacist Role in Healthy Nutrition. This is integrated in a broader program of digital events called Pharmacy Cares, supporting patients with non-communicable diseases. This program on non-communicable diseases will run throughout the year, and I would like to invite you to check the FIP events webpage to stay informed about new events. This mini-series on nutrition started last week with the event on the role of the pharmacist on the prevention and management of NCDs through nutrition, and today as the second episode focusing on the role of the pharmacist in weight management and obesity. For today's event, we have an excellent panel of speakers and will present the second part of the first ever FIP publication, highlighting and supporting pharmacists' role in nutrition and weight management, which is, of course, a key factor for maintaining a healthy life and for disease prevention, especially non-communicable diseases such as diabetes, cardiovascular diseases, and cancer, but of course, this also includes infectious diseases through a stronger immune responses. Pharmacists, you and I know, play a role in advising on appropriate dietary choices for each type of person and supporting them in adopting and sustaining lifestyle and dietary changes and informed self-care as part of our interprofessional approach to disease prevention and management in the community. On May 28 this year, a toolkit for pharmacists on nutrition and weight management services was launched. This toolkit provides an overview of evidence-based dietary options, treatment options, and professional services for nutrition-related disease prevention and management, as well as weight management services by pharmacists. We are very proud and thankful to a long list of experts and colleagues from the FIP Community Pharmacy Section, the International Diabetes Foundation, and our individual experts around the world contributing and reviewing the toolkit. This really made it a choral piece of work that is robust and useful to support individual pharmacists and FIP member organizations in adopting and implementing these services at the country and at the local level. Supporting healthy nutrition is also linked to several of the FIP development goals. The most overtly linked ones are, of course, those that are related to non-communicable diseases. If you would look at our slide, there are those highlighted that include DG 15, Development Goal 15 on people-centered care, and communicable diseases, which is Development Goal 16. We also have Development Goal 7, Advancing Integrated Services, and Development Goal 8, that's working with others. So all of these are very much addressed by this series of discussions or webinars that we have. The highlighted ones are the set from among the 21 development goals that have a stronger connection to the topic that we will be discussing. So our program today will tackle 4 very good and very interesting topics, which will be discussed by our powerful speakers, as I mentioned earlier, experts on the topic that would be discussed. So each of the speaker will be introduced anyway one by one later, as I will call them. And let me just also remind our audience or our those who are with us now that if there is any question that you may have, and I encourage you to ask questions, you can write it in the Q&A tool or you can write it in the chat box. We will be picking it up. No, we will be picking them up so that we could give it to our speakers to answer. The learning objectives that we have for today include, number 1, we wanted to understand the role of the community pharmacist in obesity and weight management, prevention, screening, and referral. And 2, we want to share good practices in terms of community pharmacy services focusing on weight management. And 3rd, discuss the importance of prevention and management of childhood obesity and the role of the pharmacist in this promotion. So to proceed, I would like to introduce our first speaker who would give us the overview of the FIP Toolkit, weight management and obesity. So our first speaker is the Global Engagement Fellow at the University of North Carolina, Schulman School of Pharmacy, and also serves in a consultant role with FIP. She graduated from Drake University in 2019 with her Doctor of Pharmacy and then completed a fellowship in association management. In the fall, she will be pursuing her Master of Public Health degree, where she will further explore the role the pharmacist can play in public health. Colleagues, help me welcome our speaker, Lorraine Bloom. Lorraine, please.
Thank you for the introduction. So with my time today, as was mentioned earlier, last week we launched a new toolkit focused on nutrition and weight management services. So today I wanted to talk about why we developed this toolkit, including why this is such an important topic, and then how we believe pharmacists can participate in these efforts. So to take a step back and to frame our conversation today, why is this important? So first of all, rates of obesity have tripled since 1975. Specifically in 2016, 39% of adults were overweight and 13% were obese. And then looking at our child population, 38 million children under the age of 5 are overweight. And then looking at children and adolescents aged 5 to 19, over 380 million are overweight or obese. And this is extremely concerning, especially since we expect these rates will likely keep growing, given that obesity can contribute to the development of several diseases and can worsen or help progress others, including some of them listed here. So our cardiovascular diseases, diabetes, cancer, musculoskeletal disorders like arthritis, and many, many more. So again, hugely concerning here, and one reason why we developed this toolkit. And then since obesity is often, but not always, a result of unbalanced diets or inadequate physical activity, this was another really important topic to address in our toolkit. So these risk factors can contribute to the development and progression of several non-communicable diseases, and they can worsen outcomes for those with other medical conditions. And then specifically, poor diets are responsible for more deaths than any other behavioral risk factor, including tobacco smoking. And then going into physical activity, up to 5 million deaths could be prevented if populations were more physically active. So these two facts together, I just think show that there is a huge potential to improve health here by addressing just these two things, and then hopefully have downstream effects of also affecting rates of obesity. And then just to get a little bit more specific as far as nutrition approaches, so in 2017, 11 million deaths were attributed to dietary risk factors, primarily these three listed here. So high sodium intake, low intake of whole grains, and low intake of fruits. And by improving diets globally, including by addressing just those three factors listed there, 1 in every 5 deaths could be prevented. So again, a huge potential here to improve health just by addressing these contributors to obesity, nutrition, and physical activity. And then getting even a little bit more specific with insufficient fruit and vegetable intake. This is estimated to cause 14% of gastrointestinal cancer deaths, 11% of ischemic heart disease deaths, and 9% of stroke deaths. So on the next slide, we see that we have this growing global health concern of poor diets, physical inactivity, and then a corresponding growing incidence of obesity. And this is contributing to diseases that we're seeing in communities around the world that are served by pharmacists. So it really makes sense that we should be playing some role here to help address these concerns. And this need is, I think, really compounded by the fact that there is this growing shortage of healthcare providers globally. So we really need all hands on deck to help address these concerns. And I think pharmacists have a really great advantage here, given that we are so accessible and trusted by the communities that we serve. So there's really an opportunity here to broach these topics and to have these conversations in places that patients are visiting frequently, since you have so many touch points. So again, pharmacists are really well positioned to help support these efforts. And with that in mind, we wanted to create this toolkit that would introduce pharmacists to these topics, especially since this is something that we're not often formally trained in our schooling. So broadly, this toolkit provides an overview of evidence-based dietary considerations, strategies to support weight loss, and guidance to facilitate the implementation of these services. And ultimately, we really hope that this toolkit supports the uptake of these services and encourages pharmacists to include these topics as part of their approach to care. And to get a little bit more specific about what we cover in here, it's quite a broad range of topics that's included in the toolkit. So we talk about non-communicable diseases. We focus on the big 4. So we have cardiovascular diseases, diabetes, cancer, and COPD, and the nutritional considerations there. We talk about communicable diseases. We have a section on additional disease states, which includes things like celiac disease, gout, osteoporosis, anemia. We talk about considerations for special populations, including older adults and pregnant women. Micronutrient supplementation is included, since patients are often going to be considering these products when they're trying to improve their lifestyles and have a healthier diet. And these products are often sold at pharmacies. We have our weight management section, of course, and then we have a section on pharmacist interventions and how these services could be implemented. And then specifically within weight management, also again, kind of a broad range of topics here. So we discuss screening methods, including BMI and waist circumference, kind of the pros and cons of each of those. We talk about some non-pharmacologic approaches, things that would be relevant to pharmacists. So things like meal replacements and self-monitoring. Within the medications section, we discuss the 5 most common approved medications, typically prescription medications that patients might use to support their weight loss. And then we talk about weight loss supplements, including a lot of the concerns around these products and their safety and efficacy, things to look out for if patients are considering these. And then finally, we include a discussion of some pharmacy programs, so examples of how these things have been implemented. So I'm going to talk about this section a little bit now, just to get you thinking about how you might want to apply these services to your pharmacies as you're hearing from our future speakers, just to have these in the back of your mind. So before we get into that, just acknowledging that there are an infinite number of ways that these services could be implemented, and it's going to look different at every pharmacy site. It's going to be a really individual decision, and you should consider, what would work best at your pharmacy? How are you most comfortable applying this information? What would be most beneficial for your patients? What would they be most receptive to learning about, or what services would they be most receptive to receiving? And then how much time do you have to implement certain strategies? So we're going to talk about kind of the two main avenues that we see for implementing these services. So first, we have educational campaigns. So this can, again, look a ton of different ways, but it's essentially about educating your community on a topic of importance to them or to you. And so it can really be tailored to whatever topic within this really broad realm of nutrition and weight management services you want to focus on. And so again, this could really look a ton of different ways and really just aims to, again, educate your community on the importance of these topics. So two specific examples that we have on the next slide. So on the left here, we have an example from Italy. This was a childhood obesity prevention campaign. So this campaign really aimed to educate parents and children on healthy food habits. So as part of this campaign, posters and leaflets, which there's an excerpt of one here, were developed and shared with community pharmacies and really promoted this 5-2-1-0 approach. So 5 or more servings of fruits or vegetables per day, 2 hours or less of recreational screen time, 1 hour or more of physical activity, and 0 sugary drinks. So as you can see here, children could mark off on each day of the week if they got each of their 5-2-1-0, and they could also partake in drawings at their pharmacies, win a prize. And so this is supposed to be a really fun interactive program that not only educated parents, but also got children engaged and kind of made this a fun game for them to help, also learn about this important topic. And then on the right, we have an example from Spain from the Plenufar program. So this was actually discussed in our webinar, our previous webinar in this series. But this specific example here is focused on physical activity. So you see a lot of very simple graphics just to highlight the importance of this topic, why you should be doing this, how you should be doing this, and really the benefits of physical activity. So really, again, drawing attention to this important issue and meeting patients where they are in the community. So then the second broad strategy, our educational campaigns are a little more indirect. You're promoting things to a pretty wide population of your patients. And then the other option that we really see is those one-on-one conversations that you might have with patients, whether informally or more formally through appointments. But something that should really guide these conversations are some of these principles surrounding motivational counseling. So these are strategies that are focused on working with patients to help them identify their own motivations for change. So instead of us telling them why they should change, it's really helping them identify why they want to change. And then your role is to empower them to make and sustain these positive changes. So weight loss can be a really sensitive topic for patients, especially if they've been unsuccessful in sustaining these changes in the past or may have had bad experiences. So it's really important to help build that trust with patients when you're having these conversations. And these 4 core skills here can be a good starting point. So first, open-ended questions are really important. So these are questions that require more than just a yes or a no. And you can really use these questions to guide the conversation to be focused on change and figuring out why they want to change. Affirmations can help to build trust between you and your patient. Show them that you're on their side, you want them to succeed, and you see what they're doing, and you're really supportive and you're applauding what they're doing. These reflective statements show that you are not only listening to patients, but you are hearing and understanding what they're saying, and that you're really engaged in the conversation you're having with them. And then summaries, so ending visits by summarizing everything that you learned, and then concluding with having patients set a goal of what they want to work on or accomplish. So kind of having that action step after you have these previous conversations gives you something to follow up on your next meeting. So 2 examples of many with more of a direct patient counseling approach. 2 examples here. So one is from England. So pharmacists were trained to take measurements. They were trained to motivate patients, to train their behavior, provide advice and support. And then within 6 months, they showed an impact on clinical outcomes. So they reduced weight, they reduced waist circumference, and even helped reduce blood pressure. So again, showing that this direct one-on-one approach that pharmacists are having with patients can really help to improve health in a clinically significant way. And then in Thailand, the other example here, just showing a little bit different outcomes, pharmacists met with patients individually for an hour to provide counseling, and they'd also worked off of this weight loss handbook that they developed. And after 16 weeks, they improved patients' intention to perform healthy dieting behaviors and increased their knowledge about overweight and obesity. So I think these two examples are just, kind of the top of the iceberg here of everything that's out there that shows that there is a real potential for pharmacists to get involved and to make an impact on weight management for patients. So building off of those two examples, again, those are just a few select ways that these services could be implemented, kind of in those two broad buckets. But even further than that, this can really, again, look a ton of different ways. So pharmacists can promote healthy diets and physical activity, whether that is through informal conversations, public health campaigns, or one-on-one formal conversations with patients. You can evaluate the impacts of nutrition and weight on a patient's health, figure out how this could be, making them at more risk of developing a certain disease or maybe causing the progression of a condition they already have. You can advise patients on appropriate nutrition choices for their disease states. Supporting patients in achieving their weight loss goals and maintaining healthy lifestyles. So again, with those frequent touch points that pharmacists have with patients, it's a really good opportunity to support them, applaud their progress, and provide whatever support that they need or that you can provide from a pharmacy. Collaborating with other healthcare providers to ensure that patients are meeting their health goals. This is especially important because these services should not take place in a silo. A multidisciplinary approach is going to be the most important way here to ensure positive outcomes, and then referring patients to specialists if needed. So these pharmacies can really serve as an entry point into the healthcare system to get patients the help that they might need. And then finally, so in conclusion, we know that pharmacists play such an important role in their communities in improving health. And there's really an opportunity here to make an even greater impact on health by integrating nutrition and weight management services into pharmacy practice, in whatever form that they take. So with this toolkit, we really hope that to encourage pharmacists to join global efforts to promote healthy diets and physical activity and ultimately reduce rates of obesity globally. Thank you.
Thank you very much, Lorraine. What a wonderful toolkit. Congratulations, and congratulations FIP for this very wonderful toolkit. This will definitely be of help to our pharmacists. What caught my attention in your discussion, Lorraine, is that you said pharmacists could be very good health coach to motivate patients to change, positive change, indeed. Thank you. Then we proceed to our next speaker. Our next speaker is Dr. Irene Om, who is a lecturer at a School of Pharmacy and a community pharmacist. Dr. Irene was awarded her PhD at the University of Sydney entitled Weight Management and Community Pharmacy in Australia. Dr. Irene Om's research and teaching aims is to improve professional practice and strengthen the pharmacist's role in the primary care setting. Dr. Irene is the program director of the University of Sydney's National Alliance of Pharmacy Education intern training program. May we call on Dr. Irene?
Thank you for that introduction. I'd also like to actually thank the organizers of this FIP digital event for inviting me to present on the topic of pharmacist-led services and approaches. I'd also like to congratulate Lauren and FIP on launching this very important toolkit, which I really believe will help develop and advance our role in the community, especially in relation to weight management and healthy lifestyle. So before I begin, I'd firstly like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I am currently on the land of the Darug and Gundungurra peoples of the Blue Mountains area west of Sydney. I pay my respects to their elders, past, present, and emerging in the future. I further acknowledge any Aboriginal and Torres Strait Islander peoples who may be attending this digital event. In this presentation, I'll briefly outline pharmacists' potential role in weight management in the community. I'd also like to share some of my insights on a weight management program that I was a part of in terms of development and piloting in Australia. And finally, discuss some considerations going forward, which may be relevant for our international audience today. Please note that the information in this presentation does not purport to be complete and comprehensive, and I have no conflicts of interest to declare. As Lauren has mentioned, pharmacists are one of the most trustworthy and accessible health professionals worldwide. We are really well positioned in the community to provide lifestyle advice as well as weight management support. Firstly, as we know, pharmacists are recognised to be medication experts. We're able to provide advice and support for people who are using pharmacotherapy for obesity. We are also able to provide advice on over-the-counter products that are used for managing weight and obesity. These include prescription medicines as well as non-prescription medicines, as well as complementary and alternative medicines. We're able to promote quality use of medicines, including safety and effectiveness. Secondly, pharmacists are in a really unique position as we are already managing many related comorbidities, such as cardiovascular disease and diabetes. Often, pharmacists are already involved in point-of-care testing, such as for blood pressure, blood glucose monitoring, and cholesterol. So why not we also look at weight management and obesity? And lastly, pharmacists are an important conduit to allied health services and professionals. Pharmacists are usually positioned in the centre of our communities. We can help refer patients on to access more specialised care, and we generally know what other allied health professionals and services are available in the local community. So generally, we're the first point of contact for most consumers and individuals. The literature shows us that pharmacy-based weight loss interventions are able to produce modest weight loss and are as effective as similar interventions in other primary care settings, such as physician offices, as well as nurse practitioner offices. And the literature also shows in a more recent scoping review by Rosenthal et al. That patients lost a mean weight of 3.8 kilograms. Pharmacists are able to successfully implement weight management services, and there are several different approaches with positive patient outcomes being able to be produced. At the lowest level of commitment, pharmacists can provide information and recommendations on both over-the-counter products as well as prescription medications. Pharmacists may also refer to other health professionals and services that may be of help to people with weight management. These could include community groups or services by local government, or even commercially available programs that pharmacists may be aware of in the local community. At this level, you could consider this would be considered to be routine or standard care. Pharmacists can also be involved in screening and health promotion campaigns and disease prevention in the community. We're in a great position to identify and tackle risk factors and promote healthy lifestyles for a better quality of life. We are already providing a lot of screening campaigns as well as services, such as for blood pressure, blood glucose, and cholesterol. So looking at healthy weight and promoting good lifestyle, whether that's through dietary intervention or through behavior modification or increasing physical activity, would also be such a great on to such existing services. At the next level, we can look at delivering individualized programs for our patients. Here, pharmacists can be involved in upskilling and being trained to provide more specialized and personalized service to individuals. We could be utilizing many of our point of care devices and testing, such as for blood glucose, cholesterol, and blood pressure, as well as using tape measures, scales, height measures to provide more of a comprehensive service regarding weight management. We may also be able to use other devices such as body composition analyzers, and even promote the use of pedometers and calorie counters for our patients, and providing follow-up services and further referral to other healthcare professionals. At the highest level of commitment, pharmacists may be involved in and deliver more of a comprehensive and multidisciplinary collaborative service where a pharmacist is involved in a multidisciplinary team. Often in these services, you would expect that there's other healthcare professionals involved, usually a dietitian, as well as a physician, and sometimes a nurse. Here, what you would expect is that pharmacists are generally providing the medication counselling, as well as support regarding the pharmacotherapy. The literature describes how pharmacists have been involved in such collaborative services, promoting the use and optimizing pharmacotherapy, as well as other product-based programs such as very low-calorie diets or meal replacement therapy. At this highest level type of services, sometimes this collaboration with physicians and dietitians can be based at group level, where the providers are in a group setting, providing more of a team approach, or the individual or patient is actually visiting one provider at a time. Either approach can be provided as an individual session or through group sessions. And generally, these can be provided over several sessions over several months. Most of these collaborative services have involved the pharmacist providing not just the pharmacotherapy counselling, but also that follow-up service, and also providing monitoring for our patients. What you would expect is for all of these programs, not only do we need to consider the first or initial consultation, but also consider that multiple follow-up consultations may be required. On this slide, I'd like to describe one example of a pharmacist-led individualized service that I designed and piloted in Australia, called a Healthier Life program. This program was a non-product centered and focused on behavioral counselling regarding diet, physical activity, and behaviour modification. At the time of design and development, the Australian government funded an initiative called the Community Pharmacy Weight Management Project. In this project, there was a conceptual macro design that was provided. Building on this project's recommendations, we consulted national experts in the field of obesity and key stakeholders to gain their expert advice and insight into the micro design or the detailed program content. Each component of the program was developed in line with the National Health and Medical Research Council's weight management guidelines for primary healthcare professionals, called the Clinical Practice Guidelines for the Management of Overweight and Obesity in Adults. These guidelines provided the evidence-based recommendations and practice points, which informed the design and the delivery of this program. Some of the key points was using the 5 A's framework, known as ask and assess, advise, assist, and arrange, which you may already be familiar with this framework or model, which has been known to be used in smoking cessation. In terms of what was involved is that we actually looked at recruiting potential participants using 3 complementary strategies in the pharmacy. Pharmacists identified clients with obesity-related comorbidities from their database of prescription clients or their dispensing records, and asked potential clients their willingness to participate in this program. Other strategies also involved clients purchasing weight loss products and initiating inquiries into their interest of participating in a non-product centered program. And finally, promotional materials were used that were displayed around the pharmacy to trigger interest and also to actually recruit these potential interested individuals into the program. Now, to detail the program, it was a multi-component intervention that looked at three key areas: diet, physical activity, and behavior change. In terms of diet, these were based on the recommendations from the Australian Dietary Guidelines and provided the basis advice on dietary intake rather than prescribing a daily energy intake. These included strategies such as controlling or reducing portion sizes, reducing intake of foods that are high in energy, or increasing more healthy options such as vegetables and fruits, as well as reducing discretionary foods, including high fats and sugar foods. We also looked at physical activity based on the Australia's Physical Activity and Sedentary Behaviour Guidelines. These were used to recommend a minimum amount of physical activity, including moderate intensity and vigorous intensity, as well as looking at muscle strengthening activities. Other discussion points with the clients and participants included reducing sedentary behaviours, as well as increasing the amount of incidental activity, such as choosing the stairs or getting off one bus stop earlier and walking the remaining distance. The third component of this intervention was relating to behaviour change. Here we looked at the individual's readiness to change, and this was considered to provide counselling or advice and support tailored to the person's readiness. The intervention pharmacist used motivational interviewing strategies to support self-management approaches, therefore promoting behaviour change. Some of the self-management approaches used included goal setting and action planning. Participants were also encouraged to use a food and physical activity diary to also self-monitor their progress. In terms of the requirements of the pharmacies that provided this Healthier Life program, it was a requirement to ensure that the pharmacy had the appropriate setting and equipment, including a private counselling room or a screened area to ensure privacy and confidentiality for the participating individual. Also, the pharmacy staff members had to be willing to be able to recruit potential participants. So if we look at this slide, in the initial session, you can see that this was a longer appointment where the pharmacist performed some baseline clinical measurements, including weight, height, calculation of BMI, waist circumference, and blood pressure. The pharmacist also performed a baseline lifestyle assessment using a lifestyle questionnaire. This helped inform some of the dietary recommendations, including nutrition and supporting the individual in terms of reducing unnecessary or discretionary food items. Further, the participants' readiness to change was assessed using an importance and confidence to make changes ruler. In this first appointment, the pharmacist assisted in goal setting and action planning, and also arranged follow-up sessions. Over 3 months, there were further follow-up sessions, which were of briefer appointment time, generally 15 to 20 minutes. The pharmacist at these appointments provided follow-up clinical measurements, mostly weight and waist circumference. The pharmacist also discussed and also evaluated the person's readiness to change and some of the difficulties that they were facing in making these changes. We evaluated their progress, as well as looking at how we could modify their action plans to be more suitable for that individual. In the final session, we were able to provide final clinical measurements and discuss the patient's and the individual's final outcomes, including in relation to their weight, their BMI, waist circumference, and blood pressure. The lifestyle questionnaire was used at the final appointment and was used to compare with the initial session to show the changes that the person had made regarding their diet. We also looked at some of their other lifestyle changes that they had made, including the increases in physical activity. Lastly, we discussed with the individual how we could actually think about weight maintenance as well as relapse prevention strategies, understanding that weight loss is not just an initial journey, but rather a long-term journey that may actually require long-term consideration over several months and years. Some of the considerations going forward that may be relevant for your context is to think about the consumer's readiness, as well as their perceptions and preferences for receiving weight management advice and counselling from you, the pharmacist. The literature generally shows that some of the studies that have looked at perceptions of patients, as well as obesity experts and clinicians, pharmacists, and other pharmacy team members, shows that it's quite favourable and it has revealed a positive perception of pharmacists' role in weight management. We must also consider some of the knowledge and training requirements of our pharmacists. We may also need to think about some of the pharmacy programs delivering undergraduate pharmacy training. What are the requirements in terms of nutrition and weight management advice for our entry-level graduates? We also need to think about creating a financially viable and cost-effective service. This is critical for long-term sustainability. Often, community pharmacies function as retail outlets, so we need to recognize there are several different commitments that may be conflicting at times, including the professional, clinical, and commercial obligations of community pharmacy practice. The last aspect is thinking about sustainability and scalability. Most studies described in the literature about pharmacist-led approaches in weight management are intervention studies. We need to consider that innovations in this setting need to be scaled up to affect nationwide improvements in health. A more recent systematic review by Weir et al. That looked at factors influencing national implementation of innovations within community practice had some recommendations, including more robust piloting of innovations, promoting a whole team involvement within pharmacies to overcome time constraints, especially considering that retail environment, as well as improving engagement strategies to increase awareness and acceptance of these innovations. Thank you for listening.
Thank you, Irene. Thank you very much. I agree with you that pharmacists are medication experts well positioned in the community, and therefore there are a lot of things that a pharmacist can do. Weight management, prevention of obesity could be one good area to be given attention to become part of the services that we extend to our client. However, what caught me in your discussion was the statement that pharmacist is faced with conflicting responsibilities, professional and commercial. But pharmacists also are very good. We term it here in the Philippines, are very good pharmapreneur. They are very good businessmen anchored on their clinical responsibilities. So thank you so much, Irene. We proceed to our third speaker. Our third speaker will discuss on experiences of advice and pharmaceutical support for weight loss in the community. She is a holder of PhD Pharma, Master in Pharmacy, Graduate in Human Nutrition and Dietetics, Master in Business Management and Administration from the Instituto de Empresa Business School, Master in Gerontology and Elderly Care from the Universidad Nacional de Educación a Distancia, Specialist in Orthopedics from Universidad de Alcalá de Henares, Expert in Management and European Quality Systems Auditor from the Universidad San Pablo CEU. Adela is a community pharmacist and an associate professor, Alfonso X. El Sabio University. She is a member of the National Board of Directors of the Spanish Society of Clinical, Family, and Community Pharmacy, Research Support Officer, member of the Board of Trustees of the CEFAC Foundation, delegate of the College of Pharmacists of Cordoba, member of the Prevention Group of the Spanish Society of Medical Oncology and other medical societies. Colleague, fellow pharmacists, let us all welcome Adela Martin. Adela, please.
Hi, good afternoon. Thank you for the introduction, Leonila. I would like to thank the FIP for their invitation. For me, it's a pleasure to represent my scientific society of community pharmacists in this matter so crucial in the future of the world population. In line with what my colleagues have previously commented, and as you can see, I have no conflict of interest. If you go to the next slide, please. You can see that the prevalence of obesity worldwide is steadily increasing. BMI of 0.4 kilogram per square meter per decade since 1918. Despite of our Mediterranean diet, Spain is no exception to this trend, but rather the opposite. We are at the forefront with prevalence figures of around 25%. 2 out of 3 men are overweight. 1 in 6 people suffer from obesity, and 1 in 3 adolescents suffer from overweight. Please, next one. In the last 40 years, eating patterns in Spain have progressively deviated from a healthy diet. Both diet and physical activity are far from the recommendations. We have more than 61% of people with sedentary lifestyle, 71% with that usually consume highly processed foods. And if you go to the next slide, you can see, please, next slide, that you can see that this is in line with the WHO says that we should avoid. No? In this slide, you can see that in Spain, we have different figures. We have pharmacists and we have graduate or nutritionists. What we can do if we are pharmacists. I am not going to repeat the information that my previous colleagues have given us, but at least you have to know that pharmacists have some specific activities as dispense prescribed anti-obesity drugs, recommended evidence-based supplementation, identify the possible interaction between food and medicines, etc., etc. Some other activities are among pharmacists and nutritionists. And really, one of the activities that nutritionists have to do, and we are not able to do, are elaborate diets. Please, next one. But Previously, to explain what have been doing during the last years as a scientific society in Spain, I would like to explain that CEFAC, our Spanish society in clinical pharmacy and community pharmacy, represent 5,500 pharmacists all over Spain. We work within working groups, and today I will show you a small part of our daily job, and including the nutritional area. Next, please. Here in this synoptic table, you are able to see different projects that I am not going to describe deeply, but at least I would like to focus on 2 or 3 points. The first one is we are trying to work with all ranges of age, from the babies, adolescents, adults, and older people, elderly people. At the same time, we are trying to promote activities in relation with other scientific societies, from the primary healthcare area to the hospital healthcare or to the specialized area. We are trying to work with patients association. And we are working, as you can see, from recommendation and papers, social media, and different activities, surveys, etc. In the next slide, I will focus on 2 or 3 programs that I think that are really important for us. One of them is MEPAFAC that is based on adolescents. We have been working with this program since 2011 with the pilot phase. It's focused on promotion of healthy habits in a school. The next one is health tents. In that case, we are promoting out of the pharmacy information about healthy lifestyles with different activities in these tents, but I will comment only those related with nutrition. And the next one is ExPERT. ExPERT is a tool developed by the society, by the scientific society, and that is a tool that is really useful for us in our daily life. At the same time, we will work with programs related with weight, but at the same time with diseases. In relation with MEPAFAC involves almost 15,000 adolescents from 12 to 17 years old. We measure weight and blood pressure in adolescents, and we did promotion of healthy habits in school. And I would like to highlight that preventing the development of hypertension, obesity, and sedentary lifestyles, educating adolescents and healthy lifestyle habits is the best way to avoid the development of cardiovascular diseases, like one of our previous speakers has told us. You can see here the map of Spain and the result that we obtained in blood pressure and in overweight and obesity in all our areas. In the next slide, you can see too our results related with obesity and overweight, where in the first table you can compare with most of the studies presented at the time with related with obesity and overweight, and our results were in line with the rest of the studies that have been published, with 29% of obesity and overweight. At the same time, we presented physical activity questionnaire, and as you can see in the upper side, our results are that children, adolescents, don't have really a good profile for physical activity, and in the future, this profile will be worse. And in the you can see also the information about the Mediterranean diet survey, the KitMed, where, as I commented previously, our children are losing the Mediterranean diet. That's why all the societies and the government is doing an effort to change the situation in Spain. For the next slide, you can see that at that time, we obtained a result, an important result for adolescents in relation with overweight that was small, higher. And at the same time, we obtained from the IoT almost 30% of overweight and obesity for these children. But there are a group of adolescents that they were underweight, 5.5% for girls and 6.2% for children. In the next slide, I will pass to the next activity, the health tents. In that case, we have two phases. The first one was realized from 2015 to 2016. We went with out of the pharmacy office to the street. We covered in our first wave 15 different cities. We involved more than 600 volunteers from the community pharmacies, and we attended almost 2,600 users attended to these health tents. Most users survived after receiving the services. They improved the knowledge of their state of health and what community pharmacists can offer them. In the second wave, you can see the next slide. From 2017 to 2019, we were to 18 different cities. And in that case, for nutritional counseling service, almost 1,700 users were attended in this poll. Based on VMI, users were identified as underweight, 1.1%, overweight, 16%, overweight 2, 24.6%, obese type 2, type 1, 22.4%, type 2, 5.5%, and obese type 3, 5.5%. Approximately 2/3 of users are overweight or obese and should lose weight. Nearly half of the users have an increased vascular risk due to the abdominal girth. The relationship between BMI and abdominal girth is different for men and women. Next slide, please. Other activities that we have done related with health education are guidelines, recommendations, and different activities related with weight loss in our community. Some of them are, as I previously commented, done. I did with medical societies and with patient association. Next slide, please. Finally, we have worked during the COVID area, and we have presented some data based on a survey on the impact of COVID-19 on eating and in community pharmacy patients. In line with other scientific society, Spanish societies, citizens during COVID-19 have increased their weight by about 2 kilograms. Next slide, please. Finally, we have developed a digital tools to help us to incorporate clinical data from our patients. As you can see, I show you the APP, the patient expert, and the base, the record, all the information that we as a clinical data that we have introduced from our patients to and trying to record to create a clinical data that from our day-to-day. Next slide. I would like to finalize that from our point of view as pharmacists can help not only on trying to obtain a reduction of weight, a reduction of obesity and overweight to our patients, but at the same time, we know it's published that obesity is related with different, not only cardiovascular diseases, but with cancer and many other diseases. Then pharmacists can develop an important role in this area. Thank you very much.
Thank you very much, Adela. What a wonderful work. A very amazing project, Adela. It's very good. Yes, I agree. Pharmacists really can do a lot in help our clients, our patients. Yeah, prevent developing or even prevent development of complications if ever they have already some NCD, some non-communicable disease. But more importantly, prevent them from getting one. So thank you so much, Adela. And then there are some questions. We'll tackle that after everyone has presented. So we will be calling our fourth and last speaker, who will be discussing on healthy aging, starts with a healthy childhood, intergenerational correlations in hypercholesterolemia and obesity. Our speaker is Jorge Robledo. He is a retired pharmacist and a high school teacher, part-time biochemist, full-time freelance researcher, an active member of the Pharmacists Without Borders of Argentina, and a PhD in health science. His main research topics are hypercholesterolemia and nutritional status in pediatric population. This is developed in Juvita, a town of 6,000 people in the south of Cordoba, Argentina. He carried out 4 epidemiological studies in 1997, 2003, 2009, and 2015, and he is currently in his 5th study. He is the director of interinstitutional prevention and health education, and he has developed a proposal of professional pharmaceutical service whose main aim is the early detection of hypercholesterolemia in children, adolescents, and young adults in pharmacy. He is currently part of a team for the development of this service with the pharmaceutical researchers from the National University of Cordoba. Help me welcome Jorge Robledo. Jorge, please.
Okay. The 5 slide, please. Well, good. Hi to all attendants. I thank you so much to FIP for the invitation for this webinar. Congratulations to Lauren Blom for the excellent toolkit that she was performing. I apologize by me for English. Both image was designed by Maria Eugenia Pica, a graphic designer who worked pro bono for the program. The left image is an icon of my research program named PIPES, Programa Interinstitucional de Prevención y Educación en Salud in Spanish, an interagency program for health prevention and education in English. The brilliant mind of a good friend, Lars Eik Sutherland, came up with this phrase that we now adopt as the program slogan and is part of the title of this speech. Thank you, Lars. Next slide, please. This is history of the universal screening in children that we realized in my later term in children from 6 to 12 years old. We performed 5 epidemiological studies in 1997, 2003, 2009, 2015. This is very important. And at this moment, carry out the 2021, the 5 epidemiological study. The number of percentage of participants in all epidemiological studies is very high. In any studies, we evaluate cholesterol, and in the last study is the lipid profile. In all studies, the body mass index of the children. In all studies, participates from 8% to 92% of the children. That is the universal screening. Next slide, please. And the study was 2015 born the project proposal of professional pharmaceutical service named FICACHA. FI es acrónimo in Spanish de pesquisa de hipercolesterolemia infanto-juvenil. At the middle is the icon of the program, is the Greek letter field, the Greek letter and the figure of the adults and children. The CAPTCHA is the acronyms in English of Children and Adult Program to Cholesterol Assessment. The main goal of this program, of the project proposal, is the early detection of hypercholesterolemia in children, adolescents, and young adults from the pharmacy office. Next slide, please. The evolution of obesity in the last year at level world, we can see in this paper was Finucane et al. Making and grant of Bill and Melinda Gates Foundation and World Health Organization. In this paper indicated that between the 1980 and 2008, the mean of the body mass index worldwide increased in 1.12 kilogram by meter square in men and 1.4 kilogram by meter square for women. Next slide, please. In Argentina, from 2015 to 2018, was realized 4 national surveys of risk factor. These surveys, we can obtain this data. The ExCo, the increase, the ExCo, that is the overweight, more obesity, is increased in this year in 12.6%. And the obesity, considered obesity body mass index major equal of 30, is increased in 10.8 in the population adult. Next slide, please. In our epidemiological study, we evaluate the obesity or the nutritional status with the tool CIT scores body mass index. Always in children to 6 to 12 years. The exit of weight increase in the 2003 to 2015 in 6.8%, and the obesity increase in the same period in 7.8%. The picture of the left show the implemented device used in all the epidemiological studies. This is important, because in all studies we use the same device, a scale, an altimeter, approved by methodology of ICE. The measurement techniques is the proposal by the roles of the Argentina Society of Pediatrics, and all study was all medication was realized by trained staff as pediatrician, physical education teacher, and myself. All this indicates a homogeneity and consequent quality of the measurement. Next slide, please. The obesity versus hypercholesterolemia. In the people in general and the many integrators of the health team, I think initialmente the obesity people continue seeing with the body fat. After seeing in cholesterol is at fat, finally seeing in hypercholesterolemia. Conclusion, the people in general really think the obesity is related to hypercholesterolemia, but this is a great misconception. I see un contingency score que es a statistical tool used for calculate odds ratio. The odds ratio is a statistical tool used for indicate or to evaluate the correlation or no correlation between two variables. Si the correlation is positive, the p-value is necessary minus the 0.05. And in this example, we can see that the p-value is more bigger, it's 0.309. But this is a statistical tool. The statistical is many complicated. It's preferable, is best we analyze the number. Enter, please. In this contingency square, we evaluate 740 children, that is all the children evaluate in the epidemiological study in 2009 and 2015. And the contingency square have two columns and two rows. The left column, these children, these obese children, that is the children with CT score of body mass index is more or equal to 2. And the opposite column is non-condition of children non-obese. And the upper row is the hypercholesterolemic children. These children is hypercholesterolemic, but cholesterol value is major or equal to 200 milligrams by deciliter, but the below row is not condition. Enter, please. In this column, we have the obese children. We can see that the 119 children obese, only 18 was hypercholesterolemic. That is, the 15% of the obese children were hypercholesterolemic, 1 of 6 or 7 more or less. Enter, please. And this, the other viewpoint, analyzing the hypercholesterolemic children, of 18 children hypercholesterolemic, only 18 was hypercholesterolemic. Pardon, older than 18 as obese. That is, the 20% of the hypercholesterolemic children were obese, only 1 of 5. This is a clearly demonstration that obesity is not related to what hypercholesterolemic. The obesity is related to what triglycerides high, and HDL cholesterol low, but no con hypercholesterolemia, con cholesterol total, o con white LDL cholesterol. Next slide, please. A consequence of obesity. At children, the principal disturbance is discrimination, problems in growth and maturation, problem dermatologic as hyperpigmentation, problem respiratory as asthma, sleep apnea, and many others. And in adults, the principal disturbance is insulin resistance, metabolic syndromes, diabetes, cancers, and many others. Next, please. In intergenerational correlation and in hypercholesterolemia and obesity. In the study of the 2015, the of hypercholesterolemia between children parents was analyzed, and we found a strong correlation. This finding was the generator to develop the project proposal FIP Capture. The correlation of obesity, we realized any study yet. But in this paper, this review, the conclusion of this review is a large number of studies have reported the parent-children association in obesity. In the study that we carry out, we take the data of weight and height of children and parents. With this data analysis, we may obtain the result of the correlation in our population in brief. Next, please. Conclusion. The hypercholesterolemia in children, adolescent, and young adults can be detected early and developing and implementing the FIP Capture program. The fights against obesity must be carried out by implementing the actions suggested by the toolkit developed by the FIP. But the fight against obesity could produce a better result if we begin at early age. Why? If we start the fight from childhood or adolescence and are successful, we can avoid the deleterious effect the obesity in adulthood. And the second reason, enter please, is because the healthy aging starts with a healthy childhood. Next, please. In this slide, we can see the symbols of the Faculty of Chemical Science of the National University of Córdoba. I am research freelance, but I am a team work con two research pharmacists of this university, Juan Pablo Real and Santiago Palma. We working in develop the project proposal FIP Capture. I invite all professional or academical, institutional, any country of the world, try transform the project proposal in project, try your implementation. This is necessary and is claimed by many integrants of the team, the physicians of the world. Thank you for attention.
Thank you. Thank you very much, Jorge, for a wonderful presentation. Now, may I call back all our speakers, our panel of speakers for questions? There are a number that we have. in the Q&A tool and in the chat box. Some are answered by our speakers already. So I would start with this question. What is the latest research saying about intermittent fasting as a lifestyle, not as a temporary measure to prevent obesity, to lower cholesterol levels, and for weight management? Are the outcomes different depending on the age of the individual? So maybe would want to answer the question. Adela, you want to say something or answer the question? You're muted, Adela. Please unmute.
Sorry. Yeah, I think that there is a Cochrane database of systematic reviews focused on this point. And I think it's a controversial point, intermittent fasting. And there are authors who say it improves and others who say it doesn't. Intermittent fasting sometimes improves, but sometimes leads to hypoglycemia, and at the same time, I think that they have demonstrated that reduce the weight, but it's not demonstrated that, or it's controversial that reduce cardiovascular events or produce any other situation.
Thank you so much, Adela. Would any one of our other three speakers like to add something? Lorraine, I think, would like to say something.
I think I'll just add on to what Adela said. I agree. I think the evidence is pretty controversial at the moment, but it's also all going to be very individualized to the patient. So if that works for them, they can go ahead and try it. But if it doesn't, it's not worth forcing that on them. So really just see what might works for them and what they're going to be able to sustain for years to come.
Oh, thank you, Lorraine. So maybe we go to the next question, which maybe could be answered by our other speaker. The other question runs this way. What is the most recent research saying about preventing obesity and other illnesses via a plant-based diet, both if such diet is followed from childhood and or started later in life? Irene, would you want to answer the question?
Adela is keen to actually answer, I think.
I will repeat.
Yes.
What is the most recent research saying about preventing obesity and other illnesses via a plant-based diet, both if such a diet is followed from childhood and or started later in life?
Adela, did you want to answer? I just noted you're not on mute.
Yeah, well, I think that they are good. Well, I think this type of diet are great, no? As long as we can take into account that it's recommended that protein intake should be 50% of vegetables and 50% from animal foods, because we have some nutrients that doesn't exist in vegetables, like biotin, vitamin V in animal foods. We need them. If you cover these needs, then you don't have problem. But on the other side, it's important to know that vitamin V12 is only in animal food, only in food, produce an anemia, a specific anemia. And if this anemia is not reduced, then you can obtain a severe cognitive disease and transtorn. And in that case, this is not reversible once the damage is established. And that's important. But you can, if you cover these needs, then they are great.
Anybody else would like to add anything, or I'll proceed to the next question?
I'll just add, in the toolkit, we talk about plant-based diets specifically for diabetes. So there is some evidence there that it may help individuals who have diabetes help mitigate some of those effects.
Okay, thank you, Adela, and thank you, Lorraine. One question is this: is 75 kilogram already obese for me at my age 53, and I am 5 feet 1 inch in height? Who would want to answer that? Maybe who? Irene, Jorge, or Lorraine? Who would want to answer? I will
I
repeat
can
the
have a go.
question. Is 75 kilogram already obese for me at my age? I'm 5 feet tall and 1 inch person.
So we use metric measurements here. So I was just trying to work out what 5 foot 1 inch is in centimeters and meters. But to calculate, maybe more generally, to calculate body mass index, we use weight in kilograms divided by height in meters squared. Having said that, BMI needs to be interpreted carefully because there are some inaccuracies associated with BMI, including ethnicity. So I'm not sure which part of the world you're coming from and what ethnicity you are, but given ethnicity is one consideration, as well as, I suppose, age. As we get older, our body composition does change. So that's something the inaccuracies we need to consider, but we also want to think about other risk factors relating to obesity. So not just BMI, but also looking at waist circumference measurement mostly, because we're also concerned about the central adiposity or the visceral fat that we carry around our abdomen, which is most concerning in relation to cardiovascular disease and diabetes.
Okay, thank you, Irene. I'll just have one more question. There are many questions, but we cannot tackle them all in the interest of time. Just one more question, then after that we'll wrap up. What kind of training and education is needed by one to become a good pharmacist who could give advice on proper nutrition? The kind of education and training a pharmacist should have to be effective in giving advice on healthy nutrition. Anybody or anyone could?
At least in Spain, compulsory materials are food science, nutrition and dietetic, and there are other electives materials, signatures, nutritional coaching, nutrient-drug interactions, food safety, diet xenobiotics, that's all.
Thank you, Adela. Well, at this point, I would like to thank you all, our dear speakers. We had a wonderful discussion tonight with a very interesting topic, and a lot of our audience are commenting that we have a very good discussion, very interesting. So much as we want to tackle questions that we still have in the question box or in the Q&A box, but then we have only 2 minutes left of our time. So I would like at this point to thank you all. Thank you for sharing your expertise, your knowledge to all of us. And I would also like to thank our hardworking team in FIP. Congratulations for another work done successfully. And most importantly, I'd like to thank our audience for joining us today, this afternoon, tonight, this morning. It's different time wherever you are. And at this point, before I would end, I would like to invite you, our dear audience, to join us in the other digital events of FIP. We have very good topics lined up for you. And again, let me reiterate the invitation to be members of FIP. It's really worth and it's good to be members of FIP. Thank you, and it's a bye for now. Thank you very much, our dear speakers.